This is a study of blinatumomab in patients with MRD or measurable residual disease positive ALL. And so we have good data from the BLAST study, which led to the approval of blinatumomab in the setting, but there was need for a confirmatory study to further support the findings from the BLAST trial, which showed a benefit of blinatumomab for patients with MRD positive disease. And also, we don't have a lot of information about the use of blinatumomab in patients with lower than with a lower level of MRD than 0.1%, which is what the current approval is for blinatumomab, and also in combination with a TKI for patients who have pH positive ALL with residual disease. So our study was designed as largely a confirmatory study of the BLAST study findings, also including patients with lower levels of MRD, and also allowing for the addition of a TKI for patients with pH positive ALL. This is a phase 2 study looking at blinatumomab for patients with MRD positive disease. We allowed for patients with either pH negative or pH positive ALL who had MRD positive at any level, particularly greater than 0.01%, which is the sensitivity of most of our MRD assays, particularly flow cytometry. Patients received blinatumomab at standard doses for up to 5 cycles of consolidation. And then subsequently, patients could either go to transplant at the physician's discretion, or they would receive about a year of blinatumomab maintenance with alternating cycles of blinatumomab about once every 3 months for 1 year. And also for those patients with pH positive ALL, a TKI could be added at the physician's discretion. So we've enrolled 34 patients with MRD positive, MRD positive B-cell ALL who were in complete remission at the time of enrollment. About 44% of them had pH positive ALL and did have a TKI added. Most of those we did add ponatinib at the physician's discretion. Overall, the MRD negativity rate was similar to that which was observed in the BLAST study, which was 76%. For patients with pH negative ALL, the MRD response rate was 84%. In patients with pH positive ALL, the MRD negativity rate was 64%, with over 90% of patients achieving MRD negativity after just 1 cycle of blinatumomab therapy. About a third of patients proceeded to transplant. We didn't see a significant difference in the outcomes for those patients who went to transplant versus not. And this is an open question, or one question that's been asked a lot about how we should manage patients who've received blinatumomab consolidation. Should we transplant them or not? Although the numbers are small, we have not been seeing a significant improvement with transplant, likely because of increased transplant-related mortality in patients who undergo transplant, but a decreased risk of relapse in those, such that the overall survival benefit is relatively equivalent. Overall, in the entire population, the 3-year overall survival rate was 65%, and the 3-year progression-free survival rate was 64%, which certainly are improved from our historical expectations for patients with MRD-positive disease in the pre-blinatumomab era. And not surprisingly, we also found an improved survival for those patients who did respond to the regimen, who achieved MRD negativity compared to those who did not. Those who responded to the regimen had a 3-year overall survival of 74% compared to only 31% for those patients who did not respond. So our findings are largely in line with those from the BLAST study, which led to the approval of patients of blinatumomab for patients with MRD-positive disease. I think we also showed that potential benefit to those patients, even with the lower levels of MRD lower levels of MRD, so even lower than the 0.1% that the blinatumomab is currently approved for. We also show safety of combining with a TKI and good outcomes for patients with pH-positive ALL when the combination of blinatumomab plus a TKI is used for MRD-positive disease. So overall, these results certainly confirm the efficacy of blinatumomab in the population, in the MRD-positive ALL population, and also, raise questions or suggest the potential for expanding the indication of blinatumomab additionally into patients with lower levels of MRD and also in combination with TKIs for those with pH-positive disease.